Okay, so here we present to you a drug-induced sleep endoscopy of a 45-year-old adult male with a BMI of 27.7, a positional RDI or positional AHI of 28.4, which is mostly in the supine position. If you look in the other positions, he has got very less a number of hypopneas and apneas. And this is also majorly hypopneas. He complains of unrefreshed sleep. As you can see on the left hand side, he has got a grossly deviated nasal septum. There is hardly any space in the left nostril. And on the right side, he has got turbinate hypertrophy, which has been shrunk by xylocaine adenine solution so that we can perform a drug-induced sleep endoscopy. Now, as we go inside, we see a lot of postnasal drip. That's the back of the soft palate. The soft palate is collapsing here. And as we see, it's mostly collapsing anteroposteriorly in the lower part. And that's what he complains, that when he lies on his back, he gets obstructed the most. So here you can see a proper anteroposterior collapse of the soft palate. These are the tonsils. As you can see, the tonsils are pretty big. That's the lower pole of the tonsil here. This is the upper pole of the tonsil here, covered by the palatopharyngeal fold. Now the BIS approaching 80, you can see a proper collapse in the soft palate. And that's an apneic episode. Make him snore. That's the proper stage. He has desaturated to his normal in the sleep, and at this point of time we see collapse of the soft palate, tonsils and the uvula, the base of the uvula and the tonsils upper part completely collapsing and blocking his upper airway. As you can see, his base tongue and epiglottis are normal. They're not really contributing to the collapse. So we understand that this patient is a good case for nasal and palatal surgery, septoplasty, turbinoplasty, and a modified uvulopalatopharyngoplasty should do extremely well with that. Thank you for watching.